Okay, so my dear professors, my dear colleagues, my ambitious students, on behalf of the Royal College of Physicians, London Iraqi Network, it's my honor to welcome all of you to our today's sessions by scientific activity domain on the lipid disorder. We are missing you so much. So, as you know from the title, a very important point. According to the WHO in 2021, atherosclerosis is responsible for approximately 75 to 85% of cardiovascular death globally, and even more than 90% of coronary artery disease death, and 70 to 80% of ischemic stroke death. So, quite a number. CVDs cause 18 million deaths annually. Atherosclerosis contributes to at least 30 to 50 million of these deaths per year. What a terrifying number, actually. So in order to have a very deep knowledge about this important topic today, we are privileged to have with us Dr. Amr Marouf, Brina, the specialist from the Royal College of Pathologists. He is a member, of course, in the Royal College of Physicians and fellowship follower of the Royal College of Pathologists, a specialist registrar in chemical pathology and metabolic medicine in Wolverhampton in New Cross Hospital. And he has developed a clinical interest in the management of diabetes, lipids, obesity, as well as metabolic bone diseases. So quite a beautiful CV. So we hopefully the aim of this hopefully get to the aim of this session tonight as introduction to lipoprotein metabolism, to understand what is the details of them, what is the lipid hypothesis, understand what is the absolute and cumulative risk of lipid disorders, and what are the evidence of statins, and what are the novel lipid lowering treatments. Of course, what is the safety utility for risk stratifications. So the session's timeline will be as shown in this table. Of course, in the end of the session, we will have a Q&A with Dr. Amru, and of course, you have a right to even to talk to Dr. Amru directly, but unmute yourself at the time of the question and a part of the lecture. Kindly, beautiful reminders to just to keep everything organized. We're asking you kindly to mute the microphones, and of course we will have a time to discussions, or you can drop or your type or your questions in the chat box below, and I will show me and my colleagues to addressing all of your questions and answer them clearly by Dr. Amr, hopefully, inshallah. And so don't forget, please, to register in the form we will provide a link for in the chat box in order to get the certificate. So without a further ado, let's go directly to Dr. Amru and enjoy this beautiful learning experience. So Dr. Amru, please, the floor is yours, dear sir. Go ahead. Thank you so much.
Thank you very much, Dr. Jabouri. That's a really lovely introduction, and I'm very honoured and humbled to have been asked to come and talk with you about lipids. So first of all, I want to thank you. I want to thank Dr. Zainab Akram Youssef, who invited me to come and talk. I work with her with in the kind of endocrine setting, and it's been an absolute kind of privilege. And as I say, I'm very humbled to have been asked to come. I think first of all, I'm just going to share my screen, and hopefully there's no issues. Okay.
Crystal clear, dear sir. Crystal clear.
Is that 1 second? I'll just put it on the slideshow. Is that in presentation mode?
And in a split screen.
It's in the so I need to change that again. Split screen.
Oh, okay. No problem at all.
Swap presenter view and slide. How about this? Is that better?
Beautiful.
Okay.
Beautiful.
Thank you so much.
Thank you,
so so like I said, so I'm Amr Marouf. I work as a chemical pathology registrar, or clinical biochemistry, sometimes we're better known, in the West Midlands region. And I am I'm just going to switch to take the camera off so I can so you don't have to look at I don't have to look at myself. I'm seeing. So yeah, so I'm going to talk to you about lipids, and thank you very much for giving me the introduction in terms of what we'll go through. Normally we have to go through our disclosures before we start lectures in terms of, but I can say I've not been paid, or I'm not part of Big Pharma. But the only disclosure I have is that I am married to a Iraqi lady by the name of Mariam Al-Aini. She's a dentist, and as her name suggests, she is from a place called Aina in Anbar province. She was born in Iraq, spent her first year there before coming to the UK and then going to Canada. But her family all hail from Aina, and they are and Mariam, like her siblings and parents, are very fiercely patriotic. So as soon as I had this wonderful opportunity to come and talk with you, my father-in-law was very keen to send me some photos of the 1980s of Aina in Anbar, and you can see the photos provided. Very pretty water wheel carrying water from the river to high levels to irrigate the land, and it really is just a beautiful uh, tranquil place from what they remember. So that's my only disclosure. That's my link to Iraq. But I am a kind of a British Egyptian born. So this is a session overview that was very kindly had gone through with by Dr. El Jabouri. I've I'm gonna I don't want to end up talking directly at a camera for or directly at the screen for 1 hour. So what I thought we could do is we could break it down, because it is quite a turgid subject, lipids, and I don't want people to kind of switch off, because the first bit is probably the most heavy bit, the first two sections. So what I was thinking we could do, with the chair's permission, is I'll talk about introduction to lipids or lipoprotein metabolism and the lipid hypothesis, and then we take some Q&A questions and answers around that, and then we talk about understanding risk and risk equations, and then we talk about some of this cardiac CT imaging that we now use, and then we take questions and answers, and then we look at the lipid lowering drugs, questions and answers, and then we discuss the cases. So I put in two cases that will hopefully summarize um, all of the above and make you think about what we do on a day-to-day clinic appointment. And these patients are taken directly from clinic, so I hope that's okay, that we do break it up a little bit. But I have to say, everything that I'm talking about is generally UK-based guidelines, and it may differ from wherever you are in the world. But I'm generally using UK guidelines and some European guidelines as well. So I'm not going to spend any time going through the cases yet, but this is just we're going to go through this in detail at the end of the of the lecture. But just have a look at this case, have a read of it of your own will. Essentially, it's somebody with cardiovascular disease who's on dual lipid lowering therapy with some other antihypertensive, antiglycemics, and just not uncommon kind of situation you'd see in clinic. These are the bloods, which I've put in both millimole per liter and milligrams per deciliter. Again, we'll talk about this in detail at the end of clinic. And all I want you to think about is, what would you do next? And the same with case two. This is a 48-year-old man who had some private bloods done, uh, and elevated total cholesterol. He had his repeated again by his NHS general practitioner 6 months down the line. And again, his bloods are shown here. Let me just get my laser pointer. So you can see the bloods here. And again, have a think about what you would do. Uh, that's his passage, but do not worry now. We're going to go through this in much more detail at the end of the discussion. Okay, so this is the boring bit. And I say boring bit because there is no way you can make uh, biochemistry of lipoproteins exciting. But unfortunately, or fortunately, we have to know it. To understand lipids, you have to understand lipoproteins. So unless if you don't get a good grasp of lipoproteins, I don't think you'll truly understand lipids. And that was my experience as an ST3, as a junior registrar, not having a clue about lipids because I didn't understand lipoprotein metabolism. So I make kind of no apologies for having to go through this again. So what are lipoproteins? So this is a nice picture of a lipoprotein, a non-specific lipoprotein, but essentially lipoproteins are complex spherical molecules that transport lipids around the blood to their target tissues. So in many ways, they're like glorified taxis or Uber drivers. Inside the lipoproteins, you have this hydrophobic, so water fearing, liquid fearing triglyceride and cholesterol esters. And it's the triglyceride and cholesterol that we measure that you'll see on your lipid panel, but these are often packed on the inside of the lipoproteins. On the outside, you've got this hydrophilic shell where you have these phospholipids, which are soluble uh, by their very nature being hydrophilic, and they and around them with this snake-like structure is this protein called an apolipoprotein. And what that protein does is it binds to receptors and it also activates enzymes. So this is, if you like, the very basic structure of a lipoprotein that we'll keep on referring to. Now, again, biochemistry, have to introduce biochemistry. Let's start by, people get confused: cholesterol, triglyceride, free fatty acid. They use them interchangeably, and they use them, I have to say, incorrectly, as I did as when I first started out. So it's really important to understand what we're actually talking about when we're talking about cholesterol. So cholesterol is a sterol, as its name suggests, and it comes in two forms: a cholesterol, free cholesterol, or a cholesterol ester. So the basic structure of cholesterol is you have these four um, um, rings with a side chain and a hydroxyl group. And the basic structure of a cholesterol ester is essentially just a free cholesterol with a free fat with a fatty acid, long chain fatty acid stuck to the side. That's as simple as you need to know. So the free cholesterol, it's found in all tissues. So every cell has cholesterol. Free cholesterol makes cholesterol, but it's mainly made in the liver. And we all need cholesterol because it's really important for our cell membrane structure. And for any endocrinologists on board, cholesterol is the precursor for adrenal steroid synthesis. So when you could think about all those really important steroid pathways of adrenal steroid degenesis, everything comes from free cholesterol. And also vitamin D uh, uh, originates from free cholesterol. So cholesterol is clearly essential for all of these hormonal processes. Cholesterol ester, on the other hand, which is, or sometimes known as esterified cholesterol, which is just your free cholesterol plus your free fatty acids stuck to it, is much more found in diet. So dietary cholesterol is essentially cholesterol ester. And as I said before, cholesterol esters, they sit here on the inside because they're hydrophobic. Whereas free cholesterol, you might get a bit of free cholesterol, which is less hydrophobic, that sits in the shell. Okay, so it's really important that you know the distinction, that when we talk about cholesterol or we're measuring total cholesterol, we're talking about cholesterol and the cholesterol ester. What are triglycerides? Triglycerides, in essence, are made up of a glycerol backbone, which is a sugar, plus three fatty acids, normally long chain or very long chain fatty acids. Okay, so you just stick three long chain fatty acids, that's why they're triacyl. You stick it to a glycerol, and then you get triglyceride. Okay, and triglycerides, as we know, is the main form of fat storage. It's found in adipose tissue, also found in muscle, but mainly adipose tissue. And it's really important. It's the main dietary fat. So when you have fats, when you're eating fats, you're actually, most of the fats that you're eating is not cholesterol or cholesterol ester. Most of the fats you're eating is actually triglyceride fat. And now triglycerides are also very hydrophobic. So just like cholesterol esters, they sit on the inside here. So again, triglyceride and cholesterol esters sit on the inside, and they're carried around the blood to where they're required by this by the lipoprotein Uber type driver to get them round. Okay. What about fatty acids? Fatty acids are, if you like, as I've said before, you have to combine a fatty acid and a glycerol backbone to get triglycerides. Fatty acids are sometimes known as free fatty acids. You might have heard them as free fatty acids. You might hear them as non-esterified fatty acids. Essentially the same things. Free fatty acids are also hydrophobic, and they're transported in the blood bound to albumin, to tissues where they're metabolized in the mitochondria of cells through beta oxidation, and in order to generate energy. So when they're taken up into cells, they undergo beta oxidation, which produces ATP, which is obviously your energy source. So these are the preferred fuel type in cardiac and skeletal muscle. So if you were to go and run a marathon, you will be using your cardiac muscle, and your skeletal muscle will preferentially be using fatty acid metabolism, not carbohydrate metabolism. So even though fatty acids are really, really important for them, for what I've just mentioned, they're actually not essential for life compared to, say, triglycerides, compared to cholesterol esters. Um, so they're one of the most important dietary fuels. Okay. And as you probably know, fatty acids, they can either be they can either be saturated, which are generally animal type fatty acids, or unsaturated or polyunsaturated. So, and obviously, these are to do with the double bonds of carbon. The more carbon bonds you have, the more polyunsaturated they are. And we always say polyunsaturated fatty acids are good compared to saturated fatty acids. So we've gone back to this picture of this lipoprotein, you've cut it in half, almost like a sagittal section here, and what you can see here is the cholesterol ester with the orange free cholesterol there with the fatty acid chain stuck to it, and the triglycerides, which is your glycerol backbone with your 3 free fatty acids making triglycerides. So if there's anything you remember from this, lipoprotein particles carry predominantly cholesterol as esterified cholesterol and triglycerides. And these are what are essentially measured in most lipid panels, triglyceride and total cholesterol. Okay, so when we're looking at lipoprotein particles, we have to differentiate it. We can't just call lipoproteins. We have to differentiate the type of lipoproteins there are, because they all do different things. Now, I'm sorry, I haven't got a slide here. There should have been another picture here of a chylomicron. Chylomicrons are really big. They're about 100 times bigger than the next biggest lipoprotein particle, which is VLDL, which is very low density lipoprotein. So it's about 100 times bigger. Very very low density lipoprotein is bigger than IDL, intermediate density lipoprotein, and intermediate density lipoprotein is bigger than LDL, and LDL is bigger than lipoprotein little a. So what you can see is, as you move from bigger lipoproteins to smaller lipoproteins, they become less dense and they become more packed full of cholesterol. Okay, patients, such that such that LDL cholesterol, low density lipoprotein, is the most atherogenic of lipoproteins because it's packed most of cholesterol. And then there is a subset of LDL called lipoprotein little a, which I'm not going to talk about today, but these are really highly dense atherogenic lipoproteins. They come from the same family as LDL particles, but these are the really bad guys. And you often see young people with premature cardiovascular disease who don't particularly have a very high total cholesterol. They don't particularly have a particularly big LDL cholesterol, but they have really high lipoprotein little a, and this often runs in families. You'll all know what HDL cholesterol is. HDL cholesterol again is packed full of cholesterol, but this is what we call the good cholesterol. It's involved in reverse transport of cholesterol from peripheral tissues. So it's really important when you look at these these particles or these lipoproteins. You start off with chylomicrons. Chylomicrons are the biggest lipoprotein, but they contain predominantly triglyceride. Remember those triacylglyceride, the fatty acid combined, 3 fatty acids combined with triglycerol. That is what chylomicrons predominantly contain. And you can see 86% of the proportion, or the inside the core of a chylomicron, is triglyceride, and you've got very small proportion of cholesterol. When you move down to very low density lipoprotein, the triglyceride concentration drops 55%, and then you've got about 45% cholesterol. And then as you start getting to intermediate density lipoprotein and low density lipoprotein, the triglyceride concentration drops further, and the main fats inside the lipoproteins become cholesterol esters. So you can see here proportionately the cholesterol goes up as you go from chylomicron to low density lipoprotein, triglycerides go down. And that's the percentages of triglycerides here. Now, what you'll see here in red is so what you'll see first of all, these are all of the we talk about the apolipoproteins, all the protein ligands that sit on the surface. I've highlighted in red the most important one you need to be aware of. This is ApoB100. ApoB100 is specific to VLDL, IDL, LDL, and lipoprotein little a. You may have heard of the concept of measuring ApoB. ApoB essentially is the measurement of ApoB100 in all of these four particles here: VLDL, IDL, LDL, and LPA. And ApoB is the most superior marker of of giving you an idea of the number of atherogenic particles you have in your blood. We often use LDL cholesterol, but ApoB is more superior. The reason we don't measure ApoB is because not many laboratories offer it. It's expensive, and we've got lots of data showing that LDL cholesterol is probably just a good surrogate marker, or as good a surrogate marker. This is going to be the final slide of biochemistry, you'll be pleased to know, before we move on to more interesting things. But I think it's again important just to split things up into how lipoprotein metabolism occurs. So you have your exogenous pathway here on the left and your endogenous pathway on the right. The exogenous pathway is basically what happens to dietary fats when we eat. As I've said to you before, when we eat dietary fats, what is the main type of fat in our diet? It is triglyceride, with 90% of its triglyceride, with a little bit of cholesterol ester that makes up dietary fat. So just very quickly, just so you understand this, when dietary fat goes in, it's churned up in the stomach. So the stomach, you get peristaltic activity of the stomach, which breaks down, emulsifies all of these fats. You get bile salts coming in from the liver, which emulsify these fats, breaks them all down in the small intestine back to their constituent bits. And we've already said the constituent parts of triglyceride is glycerol backbone and free fatty acid, and the constituent part of cholesterol ester is free cholesterol with a fatty acid. So these are all in their constituent parts, but then they're taken up here in the intestinal wall, and they're assembled into chylomicrons, where they're made again back into their parent their parent part, if you like. So they made again back into triglycerides and cholesterol esters. So chylomicrons then pass out into the lymph, and then they enter the circulation. And these here, you can hopefully see my laser pen. These are the really big, fluffy lipoprotein particles, the ubers, if you like, that carry all of the triglycerides here, which is in the light yellow, and the orange are the cholesterol esters. They takes it round to the adipose tissue predominantly, or the skeletal muscle, goes into the capillaries of these tissues, and then an enzyme called lipoprotein lipase breaks this down again, or hydrolyzes them, and then takes the free fatty acid and glycerol into the cell of the tissue, so into the adipose tissue, into the skeletal muscle. And if you're running your marathon, you're going to need your free fatty acids, because they're going to be oxidizing, undergoing beta oxidation in order to produce energy. If you're not running your marathon and you're like me, just eating and sitting home getting fatter, these free fatty acids will just be taken up back into triglyceride. And the problem is, when you store triglyceride, it's stored as, it's the predominant fat. You just put on more and more weight. Okay, so when the chylomicrons are once it's undergone hydrolysis, what are you left with these chylomicron smaller particles? You're left with predominantly cholesterol, because most of the triglyceride has been taken in. Cholesterol is just taken back in the liver. This is the exogenous pathway. What happens when we eat? The endogenous pathway on the right is what happens from the liver. The liver produces cholesterol esters, and it also produces triglycerides, and it packages them not in chylomicrons, it packages them in very low density lipoprotein, VLDL. We said VLDL is predominantly triglyceride rich, and it's smaller than chylomicrons. And the same thing happens with VLDL. They go to the adipose tissue, they go to skeletal muscle, the lipoprotein lipase hydrolyzes them, the triglycerides, and then triglyceride free fatty acid glycerols taken in, and then you end up with even smaller particle of cholesterol rich particles called IDL. Some of the IDL, intermediate density lipoprotein, is taken back in the liver. Most of it's converted to LDL by an enzyme called hepatic lipase, not lipoprotein lipase. That's wrong. It should be hepatic lipase. And what did we say about LDL? Most of the LDL is taken up back in the liver via LDL receptors. And LDL receptors are really, really important because they swamp up and clear all this excess LDL and they take them back in the liver. So you've probably heard of a condition called familial hypercholesterolemia, where predominantly there's a mutation of the LDL receptor so that you don't produce enough LDL receptors or enough functioning LDL receptors. So you get too much LDL swamping around in your blood. And that causes very high LDL cholesterol. So where does that LDL go? Well, it starts accumulating in macrophages. It starts accumulating in macrophages. And we all know, as you've beautifully demonstrated in your initial slides, um, Dr. Al-Jabouri, when LDL cholesterol, when it's circulating in macrophages, it becomes very oxidizable, and these become trapped in the intimal layer of vessel walls of arteries, predominantly coronary arteries, but also the cerebrovascular arteries and also the vasculature of the legs as well. And what we see is they start forming initially foam cells. The foam cells then encourage more cytokine attraction, and then the foam cells develop fatty streaks, and then the fatty streaks develop cholesterol plaques. And if you're lucky with your cholesterol plaques, they'll just get bigger and bigger and bigger. And then you'll have a stable, fibrous, thick plaque here that's stable. And if you're lucky, you'll probably just get angina symptoms when you're walking or running. If you're unlucky, you might develop this unstable plaque where you have this very thin plaque here. And these are the really dangerous types of plaque. These are called vulnerable plaques because they can rupture. And they're the ones we worry. We don't worry so much about stable plaques. We worry about vulnerable plaques. Vulnerable plaques have got necrotic tissue, lots of inflammatory tissue, and they're very thin fibrous cap. And when these rupture, these are much more prone to rupture. That's when a heart attack develops because you get the sudden rupture, you get thrombus development, you get the classical acute MI, STEMI, and these are what we are dangerous. A ruptured plaque is absolutely catastrophic. So when we're looking about atherosclerosis, we're thinking more about, is the plaque a stable plaque or is it this dangerous vulnerable plaque? So LDL cholesterol, we've just said, is the predominant atherogenic lipoprotein particle. Okay, so the atherogenic lipoprotein particles we've said are LDL, lipoprotein little a, IDL, and VLDL. But LDL cholesterol is the most prominent of them that we measure, that we routinely use in the laboratory. And it's really important that you remember that LDL cholesterol, low density lipoprotein cholesterol, is not measured. We don't actually measure it in the lab, we calculate it. And the calculation comes if you use European units, UK units, it's in millimoles per liter, and it's calculated by just whatever your measured total cholesterol is minus your HDL cholesterol minus your triglyceride divided by 2.2. That will give you your LDL cholesterol in millimoles per liter. If you use American units, or a lot of the Arab countries use milligrams per deciliter or mass units, then LDL cholesterol is calculated by just applying a factor of 5 instead of 2.2. Now, just because we've got an international audience, in the UK, we use millimoles per liter. So if I'm going to be seeing a report in the Middle East or America in mass units of milligrams per deciliter for cholesterol, I'm just dividing it by 38.67. If I'm seeing units of triglycerides in milligrams per deciliter, and I want to convert it to millimoles per liter, I'm dividing it by 88.57. And the reverse is true if you're going from millimoles per liter SI units to mass units. You just multiply it back up. But I'm going to use both units for our international audience. I'm going to just very briefly talk about the lipid hypothesis, and if there's an opportunity to take questions, we'll take questions before we start talking about the more interesting things. What is the lipid hypothesis? Well, I hope I've already explained it to you in some way. We've already said to you that trapping of LDL cholesterol and other ApoB 100 containing lipoproteins within the arterial wall causes atherosclerosis. So the risk of atherosclerotic cardiovascular disease depends on the magnitude and duration of LDL cholesterol exposure. So what that means in essence is the the higher your LDL cholesterol and the longer you've had high LDL cholesterol, the greater your risk is of developing atherosclerotic cardiovascular disease. So LDL cholesterol is one of those few biomarkers which is causally associated with atherosclerotic cardiovascular disease. It's like saying smoking is causally associated with lung cancer. We know that, but we also know that LDL cholesterol is causally associated with atherosclerotic cardiovascular disease because it meets these criteria. Higher and longer durations of LDL cholesterol increase your risk. And we can show that nicely here. This is almost like the equivalent of any respiratory doctors in there of your pack years of smoking. We will talk about pack years when we see patients. How many pack years do you have? And because it gives us an idea of their cumulative exposure to tobacco and the harms of it. The exact same happens with LDL exposure. So if you are me, 40 years old, and you have an average LDL cholesterol of 125 milligrams per deciliter, or if for our UK audience, 3.2 millimoles per liter, if your average is 3.2 and from birth and you're just running along at 3.2, by the time you hit 40 years old, you have reached the point at which you are at risk of developing atherosclerotic cardiovascular disease. And the magic number is 5,000 milligrams per deciliter. So all you have to do to work out is just whatever your age is, you calculate it by your average LDL cholesterol. So here, 40 times 125, I hope is 5,000 milligrams per deciliter, or if you're going to use SI units, 3.2 millimoles per liter times 40 is 130 millimoles per liter. So if my LDL cholesterol has been 3.2 for the last 40 years, um, I have already reached my risk. I've already reached a level at which I am at significantly increased risk of developing atherosclerotic cardiovascular disease. You can see it becomes on a logarithmic scale of your risk. So it becomes very, very high. And on the converse, if I've got higher LDL cholesterol, so if I've got something, so if 200, which is equivalent of around 5 millimoles per liter, which is typical of someone with, say, heterozygous familial hypercholesterolemia, because you're born with high LDL cholesterol, you are not at 40, you've pushed that forward. You reach your 5,000 milligram per deciliter cumulative exposure risk by the time you're 20. So from the age of 20, you're already at risk of developing atherosclerotic cardiovascular disease, and you're already at risk of having an MI, such that the average age of a myocardial infarction may be 35, which is obviously a disaster. Um, if you're lucky enough to have very low cholesterol, such as I think the Inuit population of Alaska, 80 milligrams per deciliter, which is around 2 millimoles per liter, you can see you've offset that risk. So by the time you hit your cumulative exposure of 5,000 milligrams per deciliter, you're already at 60, 65, such that you will die of something else other than atherosclerotic cardiovascular disease. So you'll die of something else. So what we try and do by treating cholesterol is we push people down in this section by offsetting them, that they never develop significant atherosclerotic cardiovascular disease. So there is a shift now moving to lifetime risk rather than absolute risk. And just to prove, as my final slide before we take questions for this first part, um, this was a really good paper by something called the Cholesterol Treatment Trialists. They took all of these papers, these are actual statin papers, landmark trials, and they collected them all together, and they showed that for every 1 millimole per liter drop in your cholesterol, or 38.7 milligram per deciliter drop in your LDL cholesterol, it equated to a 20 to 25% relative risk reduction of having any major cardiovascular event rate. So either a non-fatal stroke, non-fatal MI, or cardiovascular death. So I'll just repeat that again. If you drop your LDL cholesterol by 1 millimole per liter, you reduce your risk of having a cardiovascular outcome by 25%. So if you reduce it by 2 millimoles per liter, or I think whatever double that is, 68 milligram or 74 milligrams per deciliter, you actually achieve a 45 to 50% risk reduction of having a cardiovascular rate event. So this is another proof of the LDL hypothesis. We've already shown that LDL increases is causally associated with atherosclerotic cardiovascular disease, but now we're showing since the statin trials of the 90s that reducing LDL cholesterol by 1 millimole per liter equates to a 20 to 25% risk reduction because you're reducing the progression, you're stabilizing plaques. So the lower the LDL, the better. The higher the LDL, worse outcomes. So before I talk about cardiovascular risk equations, I don't know, I can't see the chat, but does anybody have any particular questions before we move on to the next bit?
Not yet, dear doctor, but
Okay,
actually a lot of things are beautiful. This is very, very. I'm very impressed by the concept of ideal cumulative risk. Beautiful.
absolutely.
Maybe at the end we will have a very good discussion
Yeah,
about
no,
it because
absolutely. We'll talk. We'll we'll
so
we'll we'll talk about risk more now, actually, if you want me to move on. But I'm more than happy.
beautiful.
People can shout out, ask questions. But we'll talk about risk now. Okay. So
Okay.
so we, this is where it gets a little bit complicated, but it's really important to understand. So relative risk is the is independent of absolute baseline risk. What do I mean by that? So I've just said to you that for every 1 millimole per liter drop or 38.7 milligram per deciliter drop in LDL cholesterol equates to a 25, let's say call it 25% risk reduction. Now that's the same for me. That's the same for you. That's the same that someone that's had a heart attack. That's the same for everybody. However, not everybody's absolute risk is the same because my risk is low, I would hope. So my LDL cholesterol when I checked it wasn't particularly high. So even though I will reduce my relative risk by 25%, my absolute risk reduction is going to be very, very low. Whereas if you've got established heart disease, you've got cardiovascular disease, you've had frequent MIs, or you're really high risk, you'll still get a 25% relative risk reduction, but your absolute risk reduction will be much greater, which is part of the reason why we don't offer statins to everyone. Because the first thing I think, well, if the first thing you might be thinking as well, if you've got a 25% relative risk reduction, why are we not giving statins to everybody? And the reason is we have to work out what people's individual risks are or absolute risk. Because if your absolute risk is low, then you are really not going to probably benefit very much for statins, certainly over 5 to 10 years, maybe over a lifetime, but not 5 to 10 years. If your risk is very high, then you'll benefit over those 5 years. So the so that's what we mean by relative risk reduction is independent of absolute baseline risk. All of our risks, everybody in this chat right now on Zoom, is if we reduce your LDL cholesterol by 1 millimole per liter, you will reduce your cardiovascular risk by 25%. But if your absolute risk is very low, it's really going to make it slightly lower, but you're not going to notice anything. But probably just get side effects from medications. And this is the concept of of um, of risk calculators that people use, and people don't, and often people don't understand how to use them. So I don't know how many of you use risk calculators. We use them in the UK. We use something called Q Risk 3. So these are absolute risk calculators. So these essentially, depending on the population that you're in, these are all, so this is for a UK based population, Q Risk 3. JBS 3 is for a UK population. Score is for a European-based population, and they have it per country. So um, American College obviously for the is for an American population. So depending on which risk calculator you use, most of these work out your absolute risk. And these are some of the other calculators being used. They use some for previous cardiovascular disease, some for people with type 2 diabetes. So there are so many risk calculators out there, I can't even keep up. Some of them work out your 10-year risk of having a heart attack. Some will look at your lifetime risk. But you can all find them this website here, which I think is free to use, youprevent.com, and it gives you really good information for your patient, depending on where you're based in the world, depending on whether they have underlying type 2 diabetes, previous cardiovascular disease, whether they're under 70, whether they're over 70, to give you some good validated data. Okay, but this is the one we use in the UK. This is a Q-risk 3. So if you ever try and fill in if I had a patient that came to me and they're like, oh, and they find that you have high cholesterol, then I will say, okay, this primary prevention, they've not had a heart attack, they've not had a stroke, so I'm trying to work out whether I put them on a statin, fill in all their details, their age, whether their gender. Apparently, postcode is independently associated with cardiovascular disease because in the UK there are some very, very poor areas, um, and people living in there's a postcode lottery, so people living in certain postcodes are more likely to develop cardiovascular disease than people that live in affluent areas. Obviously, if they're smokers or ex-smokers, are at much higher risk of developing cardiovascular disease. If they're diabetic, they're much higher risk. Family history, if they're on blood pressure treatment. So we fill all of these in, and then we put their cholesterol to HDL ratio. So notice it doesn't use LDL cholesterol here. It just takes the ratio of their cholesterol to HDL ratio, their blood pressure, their height, and their weight. So you put them all in together, and then it gives you a percentage score, which is your absolute risk. Okay, so you click the button, this is what you get. So this is for one of my patients. I put it in, and it told me that for my 55-year-old patient that I saw who had some family history, they were slightly overweight, they had slightly raised blood pressure, they didn't really want to go on a statin. I worked out they had a 14.1% chance of developing a heart attack or a stroke in the next 10 years. So, what I say to them quite simply is for every 100 patients like you who share your same blood pressure, who share your same weight, who share your same ethnicity, who share your same postcode, who share the fact that you smoked 20 a day and stopped 10 years ago, 14.1%. So 14 patients out of 100 will have a heart attack or stroke in the next 10 years. That's what I tell them. And what the UK NICE criteria said up until 2011 was that if they scored more than 20%, you should offer them a statin. They brought this down to 10%. So from 2011, 2012, it's now 10%. So in theory, if I see a result that's more than 10%, I should say to my patient, you have now hit 10%. You have a more than 10% chance. Your absolute risk is 14.1% from having a cardiovascular event in the next 10 years. Okay, that's what I should be saying to them. Um, and I should be offering them a statin straight away. But the problem is people don't like taking statins. This is and what does it mean? If I've given you a statin, does that mean that I'm now going to prevent you from having a heart attack or stroke? Does that mean that now that 14% chance becomes zero? The answer is no. And this is where maybe clinicians have difficulty explaining to patients, because if I'm a patient, I want to know, so what? There's a 14% chance. That's fine. I can get that. I get that. But if you were to give me a statin and lower my cholesterol, are you going to actually prevent me from having a heart attack or a stroke? How can you phrase that to patients in a meaningful way? So, luckily, we can do that. So, I've already told you that the absolute risk, I've already told you that for every 1 millimole or drop in LDL cholesterol, or 38.7 milligram per deciliter for using American units. So, for every 1 millimole drop, you get a 25% relative risk reduction. So, we know we can plug that in here, 25%. So if I bring a patient's cholesterol down by 1 millimole per liter, I've already reduced their risk by 25%, assuming they take it for 1 year. They have to take a tablet for 1 year before I can say that. I already know what their absolute risk is because it's already calculated it for me. So it's calculated their absolute risk over the next 10 years. So if I multiply the absolute risk, 14.1%, multiplied by their relative risk, 25%, then I get their absolute risk reduction. But so we know the absolute risk here in this patient is 14%. So I've just done it as a decimal point. So 14% is 0.14. I multiply it by 25%, which is we know is the relative risk reduction because 1 millimole LDL reduction results in a 25% relative risk reduction. There, 25%. I get this value of 0.035. or if you turn that into a percentage, times it by 100 is 3.5%. So I say to my patient, actually, you know, 25%, relative risk reduction sounds really impressive, doesn't it? Dropping your 1 millimole drop, but actually your absolute risk reduction is only 3.5%. But still, as a patient, I find that hard to understand. 3.5%, what does that actually mean? But we know, how do we convert absolute risk reduction to numbers needed to treat? We just divide 1 by the absolute risk reduction to work out the numbers needed to treat. So now I've got something more meaningful I can say to my patient who scores an absolute risk of 14.1% on the risk calculator. I can say to them, if I give you a statin and I reduce your LDL cholesterol by 1 millimole per liter, so you start off, your LDL cholesterol starts off at 4, and I bring it down to 3, out of 29 people who are going to have a heart attack and stroke, we can now prevent one of them from developing that. So you might go away and think, actually, that makes sense. I might be that one person out of 29 that won't have that stroke or heart attack. I'm going to take the tablet. But what if you've got a low absolute risk? So I plugged my figure in, and my absolute risk is 4% based on my age, based on my cholesterol. So 4%. So the nice criteria would say don't offer a cholesterol tablet anyway because it's below 10%. But just to prove that point, 4%, if you decimalize that, it's 0.04 times 0.25, because that's a constant, that's your relative risk reduction. You multiply the two together, you get 0.01, which is 1%. So 1 divided by 0.01, which is your absolute reduction, gives you your numbers needed to treat. So for me, if I was to take a statin now, um, um, I would, for 100 people like me that would develop a heart, so only I would only be able to prevent one adverse outcome. So I'd only be able to prevent one heart attack or stroke for every 100 that have a heart attack or stroke. So if you asked me, would I want to take a statin? The answer is absolutely not, because I'd be too worried about the side effects. So if you phrase that in this way to patients, they will understand better what you mean by risk. And obviously, if you reduce it down by 2 millimoles per liter, you double this. This becomes 0.07. Your numbers needed to treat becomes lower, which is half that. It's 14. If you double that, 0.02 becomes 50. So if you bring it down by 2 millimoles per liter, then you'll need, then the numbers needed to treat will be 50. So you might think that's a bit more acceptable, but it's really important that we do understand risk when we're talking to patients, and you think about it in these terms. What does relative risk reduction mean? What does absolute risk mean? What does absolute risk reduction mean? And converting it to numbers needed to treat. But not everything is that easy in life, unfortunately. We've just filled things out of a very arbitrary risk calculator. How do we know that they've got a family history of premature cardiovascular disease? Have they asked every parent, auntie, uncle? How do you know that their cholesterol to HDL ratio on that day is a constant? It might be that the LDL varies on a different day. How do you know? How can you be sure that the blood pressure you took in clinic for them wasn't high because they were stressed? So you're making a lot of assumptions here based on, your one blood result, on a one blood pressure reading, on their ability to recall their history before you offer them lifelong treatment. So some people feel that actually using these risk calculators are like throwing a dart, where really you just don't know what's going on. We should all be here. We should have high precision, high accuracy, but maybe we're somewhere over here where we're just making guesses about who we should be treating. So if we could somehow find a way of making sure that we get high precision and accuracy so we know who we should be giving cholesterol lowering treatment to, then that would make things better. And over the last few years, we have been able to do that through something called cardiac CT. So cardiac CT, what does that mean? Okay, so cardiac CT, there are two forms of cardiac CT. There is a CT coronary calcium score, which is an unenhanced CT scan. So there's no contrast. It just does a very simple 3 millimeter plain sections through the heart. It takes a few minutes. And there's something called CT coronary angiogram, which gives you three-dimensional views, really beautiful pictures of the coronary arteries. So the first one I'm going to talk about, which is mostly used, is the simpler of the two, coronary artery calcium score. So we can now work out people's coronary artery calcium score by just putting them through a scanner. So what is a coronary artery calcium score, or it's sometimes called a Gatson score, named after the person who founded the coronary artery calcium score. So I'll just call it CAC score, so I don't get trip up here. Um, a CAC score quantifies the amount of calcium deposits in the coronary arteries. Okay, so it looks for calcification. So you're given a score by multiplying the area of each calcified plaque on your coronary arteries by the density factor, or something called Hounsfield unit, and then you add up all the scores to give you an overall value. And what we know is the higher your calcium score, the greater, the higher the score, the more associated it is with developing coronary heart disease, which is really intuitive. If you've got more LDL cholesterol and you develop more atherosclerosis and you have developed more stable plaques cause calcification. Calcification is proportionately linked to coronary heart disease. And we know that because we've already demonstrated how coronary arteries develops in an artery, and there is nothing else that causes calcification in coronary arteries other than coronary heart disease. So when you see calcification, you know it's coronary heart disease. So if we somehow to utilize these calcium scores, we can actually improve these rather blunt tools of absolute risk calculators. So, but how are we going to put everybody through a coronary artery calcium score? I mean, we live in the NHS that I work in it has no money for anything, so you have to fight very hard just to get a single scan or an expensive blood test because everything costs money. So you can't put everybody through these scores through CT scans. So you have to select the right patients. So this is just an example before we talk about which patients to choose. You can see on the top, these are 4 different patients. You can see the calcium scores on the top: 0, 29, 250, and 1200. So I'm not a radiologist, but I can't see any real measurable calcification here. Calcification is really dense and bright. First thing I can see is around the coronary artery here is this calcification there. So what the radiologist has done is they've measured the density of they've measured the area of this. So they use their arrows, measure the area, and they multiply it by the Hounsfield unit, and they've come out with a score of 29. Here you can see they've got more calcific plaques. So they take each of these calcific plaques, they measure they take the diameter, they multiply it by the Hounsfield units or density, they get a score for each one, and they add them all together, and they've come up with a score of 250. And this poor person here, you can see their coronary arteries are completely full of calcium, so that they score them at 1,200. So you can see here severe coronary artery disease, moderate coronary artery disease, minor coronary artery disease, no coronary artery disease. So it's really, really intuitive. And we know from a landmark trial called MESA, Multi-Ethnic Study of Atherosclerosis, that was a prospective cohort of 7,000 patients, they found an independent and graded association between calcium score and adverse coronary events. Okay, so this person has very high risk of developing a coronary event within 5 years. This person has close to zero or close to negligible risk. And this is how you can interpret these patients. So if you run someone through a scanner, a coronary calcium score, and they score zero, you can say to them that there's very low risk over, we say 5 years, some say 10 years, but certainly in our trust we use 5 years. We say that there is a next to negligible risk that you will develop, that you will have a heart attack or a stroke, based from atherosclerotic cardiovascular disease, because you just don't have any atherosclerotic cardiovascular disease. If you score 1 to 100, your risk is probably less than 10%. If you score 100 to 400, you're in the moderate risk group. And in this group, we start using something called percentiles based on age. Because if you're 20, if you're 40, and you've got a calcium score of 400, that's really worrying. You are going to be in the top 25% percentile. If you're 73 and you've got a calcium score of 300, that might be probably normal for your age. And obviously, more than 400 is very high risk. So we can now start stratifying people into their risk far better than just using those simple risk, those simple risk equations. So what can we actually conclude from a calcium score? What we can say to patients is the absence of coronary calcium is a negative risk marker that confers favorable prognosis. So we can say to them there have been, as a meta-analysis of 72,000 asymptomatic patients with high cholesterol, and they were found to have a cardiovascular event rate of 0.47% over 5 years. So less than 1% over 5 years with a calcium score of 0. So we can reassure these people, you are fine, you do not need to take a statin. Okay. So the negative predictive value of 0 appears greatest at individuals at intermediate risk by traditional risk calculators. So these are the people that you're going to select them in. You're not going to select them in people who've got a score of, say, like me, of 4%, because a low risk is likely to translate into a low risk. Equally, you're not going to use it on somebody who's got an absolute risk on a calculator of 40 or 50%, because it's still going to be high risk. You really ought to be getting them and treating them. You're going to be using it on those with intermediate risk. So somebody maybe around that 10% mark that we talked about, who doesn't want to go on a statin. Some patients who might be 10, 11, 12, 13%, and you would otherwise put them on a statin because they're intermediate risk. You can actually reclassify them after putting them through a CT scanner and downgrade their risk and say, actually, you've got no calcium. Your risk over the next 5 to 10 years is so low that you do not need to take a statin, and everyone goes home happy. And equally, the converse might be true. Someone is really worried about going on statins because they heard all the negative side effects. They score 10%, 11%. They're saying, nope, I don't want to go on it. You put them through a CT scanner, and then you find that they've got some calcification, and you say, well, actually, you've already got early cardiovascular coronary artery disease here. Um, let's prevent that from developing further. So go on a statin. And that's been really powerful for some of our patients. They've seen that. They get very scared about calcium in their coronary arteries. So they decide, actually, I'm going to take my statin, because you want to prevent them, as we've shown that graph before. You want to try and move them away from developing an actual myocardial infarction by moving to the right-hand side of that graph. What are the limitations of a calcium score or a coronary artery calcium score? I've said to you, it's not helpful in very low risk patients, not going to add any more information. It's not helpful in very high risk patients or those with coronary artery disease. If you're symptomatic, if you've got chest pain, there's no point doing a coronary artery calcium score, because coronary artery calcium score, they just give you a reference point in terms of the calcium burden. They do not tell you anything about luminal stenosis, about the degree of stenosis um, of each of the coronary artery territories. So it's completely pointless. They need more. They need another type of imaging, either CT coronary angiogram or myocardial perfusion scan or stress echo or invasive angiogram. Okay. The other thing which causes a lot of anxiety is this notion of non-calcified plaques. If you remember right at the start of the presentation, we were talking about the evolution of plaques. We said plaques have two fates. They can either be stable plaques, where they develop a thick fibrous capsules and become calcified. These are the ones where a coronary calcium score will be able to pick up. But the ones that we worry about are those that are non-calcified, those really vulnerable plaques which have not developed, which do not have any significant calcification. So rarely you might find a calcium score of 0 in somebody who will still go on to develop a myocardial infarction. And the reason being is because they've got non-calcified plaque, which attenuates differently on imaging, that cannot be identified on a coronary calcium score. And they're the ones you have to worry about. So the jury is still out. What we say is we do not do calcium scores, coronary calcium scores, on anyone under 40, because under 40, you haven't really had the chance to develop calcification. Calcification occurs through many years of atherosclerosis. And often early on, you might develop some some vulnerable plaques, an early vulnerable plaques, which is not going to be picked up under the age of 40. And that's often seen in patients with familial hypercholesterolemia. So if I had a patient under 40, I wouldn't put them through a calcium score, coronary artery, sorry, a CAC score. I'd put them through a CT coronary angiogram because I'd want to be identifying uh, uh, those vulnerable non-calcified plaques, which are more dangerous. So I'm just going to briefly talk about CT coronary angiogram. CT coronary angiogram is another non-invasive technique of the coronary arteries. We use it in those with chest pain. So if you've got someone with chest pain who doesn't have coronary heart disease, established coronary heart disease, you might want to do a CT coronary angiogram just to see if they have any significant luminal narrowing to explain their chest pain. And in the US, they've now started using CTCA with patients presenting with chest pain and an intermediate risk. We don't tend to use that here in the UK so much. But the good thing about CT coronary angiogram is that they have a very high negative predictive value for excluding moderate or severe coronary stenosis. Okay, so a patient with significant stenosis that's going to cause symptoms, more than 50 or 70%, if you find that they do not have significant stenosis less than 50%, you can be quite confident that the cause of their chest pain is unlikely to be angina and that you don't need to go on to an invasive angiography. So you're sparing them from really invasive tests such as invasive angiography. There are some limitations of CT coronary angiogram. You can overestimate the luminal stenosis. So I said it's sensitive, it's got high negative predictive value, but it's not highly specific. We sometimes find patients, we do a CT coronary angiogram because they've got a familial hypercholesterolemia, we're worried about non-stable plaques, they might have a bit of symptoms, and then you find that, goodness me, they've got 80, 90% stenosis, and then they end up having an angiogram and they've got very minor coronary artery disease. So the problem with CT coronary angiogram is it can overestimate the degree of stenosis. So it's a good rule out test, maybe not so much a rule in test. You have to also lower their heart rate, give them beta blockers before to get the heart rate below 60. In order to get good images of the CT, of the coronary arteries, you need to give them an IV contrast agent before they go in the scanner, and it's much more expensive. This is just a picture taken of CT coronary angiogram that's been graded. There's no coronary artery disease, minimal. I can't see where it's minimal here. I'm not a radiologist. Mild, I can just about see here, some nipping here of intimal thickness with coronary artery disease here. Moderate, it's more prominent here. It's probably more than 50%, and severe here. It's almost obliterating the coronary artery here. So, what if you were to see this in a patient? If they had no coronary artery disease, you'd reassure them. If they had minimal or mild coronary artery disease here, I would make sure I treat them with a statin. If they had moderate or severe disease here, I would be thinking about some other form of cardiac imaging. I'd be emailing or writing to the cardiologist saying, could you look at considering myocardial perfusion scan to assess the territory of the artery? Could you be looking at invasive angiogram? Because I'm worried about the degree of stenosis here. That's what we'd be doing here. So just to compare the different types of CT modalities, CT coronary artery calcification, you don't require contrast, you don't need to lower the heart rate. It gives you a good information about the calcified plaque burden. Only 5 minutes through the scanner, and it's cheap, relatively cheap. CT coronary angiogram uses a lot more radiation, takes much more pictures, much longer through the scanner. You have to beta blockade them to get their heart rate down. You have to give them a contrast, and obviously we worry about contrast reactions and renal function. And it's much more expensive. It's about 3 times the cost. So most of our patients, we could probably put through CT coronary artery calcification, those who that are asymptomatic, they don't have chest pain, they've got an intermediate risk factor on a standard risk equation, and you're not quite sure whether you should offer them statin or not. CT coronary angiogram we'd use for the really high risk patients. We think, actually, I'm really worried that they might have non-calcified plaques. They might be young with familial hypercholesterolemia. they might have had a long history of diabetes, smokers. Really high risk with very strong family history with some atypical chest pain. I might offer a CT cardiac angiogram. So I'm going to stop talking here. And before I talk about pharmacotherapy, are there any questions at all relating to anything we've talked about before? Because I'm just going to talk very quickly about the pharmacotherapy of statins, and we're going to go back to the cases before we close.
Um, Thank you so much, dear Dr. Amra. Actually, very impressive. A lot of topics actually had been discussed, and I wanted, may I say something, because we have a lot of medical students with
Okay.
us. This is the beautiful link between basis and clinical application. There's nothing more to compare with. So a lot of medical students had struggled with basics. They said that basics we don't use them anymore in clinical applications. But we see through this beautiful lecture with Dr. Amr that actually a very, very good relationships between understanding basics and what is the clinical applications of them. So please be sure that whatever you learn through this long journey, it will be applied very powerfully and very beautifully in the clinical sessions. Thank you
Uh,
so much, Dr. Amr, for this beautiful elaboration.
No, no,
So
thank
I
you
have
very much.
Yeah, thank you so much.
So,
I have a question related to what you already mentioned. Um, the lifestyle modification points here. What are the collaboration with your clinic, there, doctor, and maybe a dietitian clinic? Is there any collaboration between all of them, especially in patient with intermediate risk, those who are indicated to do CAC scans or calcium score? Is there any rule for lifestyle modification, and until what point I can rely on lifestyle modifications before
and,
I change to
so
pharmacotherapy?
that's an excellent question. So, in an ideal situation, every lipid clinic would have a dietitian attached to it, and the dietitian would be able to give them really thorough advice to try and lower their LDL cholesterol. In practice, the NHS is very resource poor. We do not have access to dietitians for routine hypercholesterolemia. So what we tend to do is we signpost them to two websites. One is from something called Heart UK, and I'm happy to put it in the chat at the end. And one is the British Heart Foundation. So I signpost them to these two websites. I say, go to Heart UK, go to British Heart Foundation website, type in. You'll see within the tabs, you'll see information about dietary fats. Click on dietary fats, and it will give you really good information on how to lower your dietary cholesterol. Now, the second part of your question is really important. How long do you persevere for? Now, if we talked about the LDL hypothesis, LDL exposure is causally associated with coronary artery disease. So if I see an LDL cholesterol in clinic of 4, in a 45-year-old who's clearly just not eaten well for the last few months, might have gone for a carnivore diet, might have put on some weight, and the triglycerides are elevated, I'm not going to put them straight onto a statin, irrespective of their Q risk. I'm not going to put them straight through a CAC score. I'll be trying to look at those environmental factors, and I'll say to them, okay, what do you think's happened for this cholesterol to be poor? And often there's a reason. Often they've let themselves slip. They're eating all the wrong things, and I'll give them 6 months, and 6 months to a year, and then 6 months to a year. Some patients significantly lower their LDL cholesterol. So when you put them back in the risk calculator, they fall maybe below 10%, and then we say, actually, you're fine. Others will just move a little bit. Others won't do anything. It will stay the same. But the problem lies in something called clinical inertia, and this is what we're all which is what we're all we're all guilty, sorry, of doing, is allowing patients to dictate terms for too long. It's like diabetes. The number of times I see HbA1cs that are really poorly controlled, and the patient says, oh, I've had too much sugar, I've done this, I just need to lose a bit of weight, 6 months, and then they come back and the HbA1c is still 70 millimole per mole, or 8 or 9% in old money. And then you say, okay, give me 6 months, and then you wait another 6 months, and the same thing happens, and then you give me another 6 months, and the wait. And that's the dangerous thing. And the same thing occurs with lipids. You just have to be careful. We talk about the magnitude and the duration of LDL cholesterol. I don't like leaving it for too long, but you always give the patients the opportunity to try and lower their fats themselves. Now, if they have a genetic hypercholesterolemia, which I've not talked about, so if they have familial hypercholesterolemia, their LDL cholesterol will have been high since birth, and there is very little they can do with their diet to lower their LDL cholesterol. So they may not worsen that. We still advise them to have low fat diets in order for them not to worsen it, but you're never going to get your LDL cholesterol down to anywhere near a sensible level that's going to prevent you from developing atherosclerotic cardiovascular disease. So these patients with genetic dyslipidemias, we will always start them on a statin straight away. So I hope that answers your question.
Very clearly, crystal clear, dear doctor. Thank you so much.
Brilliant.
So, dear attendees, if you have any question, you can type it in the chat or raising hand if you want to talk directly to Dr. Amro.
Shall I move to the pharmacology and then we'll go to, or shall I, any other questions or?
I think you can, dear sir. Yes.
Okay, brilliant. So I'll go through the pharmacotherapy. I'm going to briefly go through these. Bear with me. So once you've treated somebody, or you know how, so or you've identified someone's risk, you need to know how far you treat them, how aggressively you treat them, depending on their baseline risk. So if you remember, we were talking about baseline risk. So, if you start off somewhere here with low risk, you don't really need to push their LDL cholesterol very, very low. You can just keep it relatively slightly higher than average. You know, Equivalently, if you've got someone that's had 2 cardiovascular events within 2 years, you are never going to want their LDL cholesterol of 3 millimoles per liter, because they'll continue having further cardiovascular events. So you want their LDL cholesterol to be as low as possible. So the lower the better when it comes to people with cardiovascular disease. So then you end up getting the spectrum in the middle. Now this score here is another risk calculator, but this is looking at fatal, is your 10-year risk of having of essentially all-cause mortality. So it doesn't translate well into Q risk or Framingham, so it's slightly different. So not to confuse you, this is not looking at non-fatal MI or non-fatal stroke. This is looking at your pure risk of dying. But you can see, so if you've got familial hypercholesterolemia, uh, uh, um, and you've already got angina or you've already had a stent, you need to have your LDL cholesterol of 1.4 millimoles per liter. 1.4 millimoles per liter. If you've got any form of atherosclerotic cardiovascular disease on imaging, so we said clinical or imaging. So if you've done a CT scan and there's significant calcification, I'm going to want their cholesterol to be down to 1.4 millimole per liter. And the reason being we want it down to 1.4 millimoles per liter is because they're already at that 5,000 milligram per deciliter lifetime risk, where they're at significant risk of an event. So you're trying to get them to the right hand side and prevent them from having that heart attack. So we know from the LDL hypothesis, if you leave them at 3, they will have that heart attack. So you have to kind of work through risk. This is what the European guidance is on LDL. In the UK, we do not use this so general practitioners don't use this, non-lipidologists don't use this. They use NICE criteria, National Institute of Clinical Excellence, but most lipid clinics, specialist clinics, use this. So that's why I've put this slide up here. So this is the European Association of Atherosclerosis, or European Atherosclerosis Society, ESC guidance. I'm just going to talk very briefly about the different types of treatments we offer. So this is just an overview of the mechanism of action of the treatments we offer, and I'm going to start off with statins. So, sorry, back to the very basic biochemistry. This is a liver cell. Liver, as I said to you at the start, makes cholesterol, and it packages them up in VLDL, very low density lipoprotein. We know the rate limiting step of cholesterol synthesis is an enzyme called HMG-CoA. And if we are HMG-CoA reductase, apologies. So HMG-CoA reductase is the rate limiting step. So statins work at blocking the conversion of HMG-CoA to mevalonate. So if you block that conversion, downstream you get lower cholesterol efflux from the cell. And not only do you get lower cholesterol efflux from the cell, you trick the cell into thinking, "Oh my goodness me, I need to get more cholesterol. I have to get more cholesterol." So the LDL, the LDL, the cell starts upregulating more LDL receptors because it thinks that there is not enough cholesterol in the cell. So what happens when you upregulate more LDL receptors? You get more LDL, like low density lipoprotein, in this in the blood being taken up via the liver cells. So it sucks more cholesterol in. And that's simply how statins work. And again, these are all the statin trials that we talked about. So there is no more convincing drug, I think, in history that's undergone so much cardiovascular data than statins. Here are all the statin trials, across high risk primary prevention, secondary prevention. And as I said before, they've shown a 1 millimole per liter LDL reduction equates to a 25% relative risk reduction. This is just a subgroup analysis of the statin trials. I won't go through all of these, but whichever way you cut it, if your pre-treatment LDL cholesterol is low or high, if you're 65, 65 to 75, if you're male or female, if you've had a heart attack or not, your relative risk reduction falls around 25%. Okay, that's what we said, that relative risk reduction is a constant. The only slight exception is if you've got type 1 diabetes. For some reason, it doesn't reach significance because it overlaps that line of unity of 1. That's not to, and the reason is probably because patients with type 1 diabetes have, they're generally younger onset diagnosis than those at type 2. In the trials that were recruited, they're smaller in number, so they've not really reached statistical significance based on the size effect or population size effect of the study. But we would certainly still treat patients with type 1 diabetes aggressively because they're very likely to have a lifetime of atherosclerotic cardiovascular disease development. Similar those with over 75, for the simple reason patients over 75 often don't live long enough to see the benefits of statins over 5 years. But we would, if they had high risk, we'd still probably treat them. Um, this is the rule of 6%. This is, so again, if you're going to remember anything about statins, we don't use 80 milligrams simvastatin because of the myalgia. We use 80 milligram atorvastatin, but we don't use 80 milligram rosuvastatin. So the maximum dose, to all intents and purposes, is rosuva 40, atorva 80, and simva 40. But it's the rule of 6%. Once you start a patient on a baseline dose of Simva, Atorva, or rosuvastatin, that's where you get most of your LDL reduction. Whether you use 5 milligrams of Simva, 5 milligrams of Atorva, or 5 milligrams of rosuvastatin, that's where you get most of your LDL reduction. Every time you double the dose, you only add another 6% LDL reduction. So, often if you've got a patient who's got muscle aches and pains from atorvastatin, but you're not quite got their LDL to target, there's probably little point in doubling their dose from 40 to 80 milligrams, because all you're going to do is give them myalgia, get them to stop the statin, and then they won't take it, and then you've lost that fantastic benefit of that LDL reduction of 50%, because all you're going to gain is just another 6%. So just think about that. Doubling the dose of statin only gives you another 6%. What are the side effects of statins? People, I call statins the nocebo effect. So you've heard of placebo. Placebo, obviously, is you give someone water, but you tell them that it's a really powerful drug and they feel better. Statins have the nocebo effect. As soon as you tell them you're giving them a statin, everybody gets aches and pains and no one can take it. And it's unfortunately the reality of people hate taking statins because they think they get aches and pains. But in reality, from the trial data, the risk, only 50 to 100 per 10,000 patients over 5 years develop any myalgia. Myopathy, defined as weak muscle weakness with an elevated creatinine kinase, was 5 in 10,000, with an even smaller risk of rhabdomyolysis, 10 per 100,000. What you need to be aware of is that there is an association between incident diabetes and statins. So 50 to 100 patients per 10,000 will develop new onset diabetes when you give them a statin. And it's important that you tell patients that, because statins are diabetogenic. However, those that are likely to develop diabetes already have high risk of developing diabetes. So they're normally pre-diabetic, they're normally overweight. They have metabolic syndrome, which puts them at higher risk. There is a very small risk of intracranial hemorrhage, which most people don't know about. Very small association, 5 in 10,000. I don't normally tell patients that there's a 5 in 10,000 risk that you might have an intracranial hemorrhage, because that will scare them off. But what I do is, if a patient has had an intracranial hemorrhage on a statin, I stop the statin, and I'd probably think long and hard about restarting it. Serious liver injury, 1 in 100,000, very, very rare, which is why we measure monitor the LFTs. Some patients say memory loss. So I see it regularly. You could give patient a statin, they say, oh, I've got memory impairment. This is something in real world data that's not really been replicated, and certainly not in trial data. But anecdotally, patients say, oh, they get a bit of memory loss, but as soon as you stop the statin, they're fine. So you just have to be mindful of that. I'm just going to quickly move on to other medications because of the interest of time. Ezetimibe, you've probably heard of ezetimibe, esotrel zetia. This is the second drug most likely prescribed in statin lowering, and ezetimibe works. So we said here, statins work at reducing cholesterol synthesis at the level of the liver. Ezetimibe works at reducing cholesterol absorption at the stomach. Now, if you remember what I said right at the start, most of your dietary fats are not cholesterol esters, they're triglycerides. So you're actually only getting a little bit of reduction in absorption of cholesterol from giving ezetimibe, by virtue of the fact that most of the lipids of the saturated fats you eat are actually triglycerides. But it works by essentially binding onto a receptor called Niemann-Pick-like 1. Niemann-Pick-like 1, C1, binds to a protein called clathrin AP2, and essentially this requires this to shuttle cholesterol out into the lymphatic system and into the blood. So if you block this with ezetimibe, you block cholesterol uh, packaging into the blood. It's effective. It's not as effective as statins, but when you use it on its own, you might get on average a 15 to 20% LDL reduction as monotherapy. If you use it with statins, you might get a 21 to 27% reduction in LDL cholesterol with statins. So remember that rule of 6% with statins. If you've already got someone on a atorvastatin 40 milligrams and you've got, say, an LDL reduction of 40 or 50%, you are better off adding ezetimibe to further reduce by 27 to up to 27% than just doubling the dose of the statin, because you're only going to get another 6% reduction. So using dual therapy of ezetimibe and statins is good. And we know we've got good cardiovascular outcome data with ezetimibe from this trial called Improve It. I won't go into the details of this, but essentially there was a reduction in major adverse cardiovascular events in those taking simvastatin plus ezetimibe compared to those taking simvastatin plus placebo. Again, the absolute risk was small of 2%, but it was still a significant reduction. So anybody that has a heart attack ends up being put on high dose statin, normally atorvastatin 80 or atorva 40, Rezuva 20, Rezuva 40 plus ezetimibe, because of the Improve It trial. So most guidelines now adopt high potency statins. I'm going to talk about PCSK9 inhibitors. These are the new kids on the blocks now. All right. So PCSK9 is a protein that's made in the liver. So again, a bit of biochemistry. The liver secretes this, if you look, this purple crescent here, which is called PCSK9, secretes it from the liver. And what PCSK9 actually does is it binds to LDL receptors on the surface of the liver. And if we remember, LDL receptors are good. We want more of them because they suck in cholesterol. But PCSK9 binds to these LDL receptors, and it takes them inside the cell and destroys them. So they undergo degradation through these lysosomes, and it prevents them from being recirculated back up into the surface. So the more PCSK9 you have, the more LDL receptors end up getting internalized in the liver, degraded in the lysosomes, and then you get a reduction in LDL receptors. But we need LDL receptors because LDL receptors will suck in our LDL cholesterol. So now we're in the era of PCSK9 inhibitors, which are these green things here, which are monoclonal antibodies. So if you give them these monoclonal antibodies, they bind to PCSK9. So if you bind to PCSK9, you free up these LDL cholesterols from being bound to PCSK9 so that they can start taking more LDL receptors. So you don't get this internalization of LDL receptors. You get much more LDL receptors on the cell surface. So these are called PCSK9 inhibitors, and since 2016 they've been available. They're called evolocumab and alirocumab. They have revolutionized care because you can get up to 60% lowering in LDL cholesterol. The trials, FOURIER trial, I'm not going to go through this, these are on the slides, showed a significant reduction in LDL cholesterol in patients already on statins. So again, if you look at the major adverse cardiovascular event in 2.5, just over 2 years, 9.8% of patients who were on evolocumab developed a cardiovascular event compared to 11.3%. So they worked out that the risk reduction or hazard ratio was 15%. So you have a further 15% reduction of reducing your risk of having a cardiovascular event when you give them these drugs here of evolocumab or alirocumab. So it is very, very well tolerated. And these are I'm just going to close the window because someone's quite loud outside. Bear with me. Here, this is, I'm not going to go into these slides, but this is just showing a Kaplan-Meier curve from the New England Journal of Medicine, showing these trials of how effective they are. Inclisiran, this is just the final tablet medication I'll talk about. Inclisiran is the newest kid on the block. Inclisiran is an injection called a small interfering RNA, and this also works by blocking PCSK9, except it doesn't block PCSK9 directly. It actually blocks the translation of PCSK9 from the nucleus. So it blocks it from being translated and producing the protein PCSK9, and so it actually works further back at the level of the nucleus. So this, if you like, is a gene therapy, and it targets the liver, and it reduces LDL cholesterol again by around 50 to 60% in the trials, and it's very well tolerated. The only problem is, and this is the in red, inclisiran is still not although it's approved and we use it in patients, there's no cardiovascular outcome data. Remember with the statin trials we said before that for every 1 millimole drop in LDL cholesterol equates to a 25% risk reduction. PCSK9 inhibitors showed an additional 15% risk reduction. Inclisiran as yet have not published their cardiovascular outcome data. So we're being a bit risky by giving this drug to patients where we know it lowers LDL cholesterol, but we haven't proven that it reduces heart attacks and strokes. That's only going to come about in 2027 when they publish the data. But if you've learned anything from this slides today, what we talked about was the LDL hypothesis. If you're going to reduce LDL cholesterol by whatever means, that should lead to a reduction in cardiovascular events. So we fully expect that inclisiran will work. So you might ask, why are we giving patients inclisiran? Why are we giving them alirocumab? Often we give it to patients who've not hit that LDL cholesterol of 1.4. Remember we said if they've got heart disease, patients with cardiovascular disease, and you want to get their LDL cholesterol down to 1.4 millimoles per liter, if they're on a maximum dose statin and they're not there, or they can't tolerate statins, then we'll put them on alirocumab or evolocumab or inclisiran to get them right down to massively reduce the risk of further cardiovascular events. I didn't say it's the issue we have in the UK is funding. So even though I've said all of that, we have a funding problem in the UK where we can only give it to patients who have an LDL cholesterol of 2.6 for inclisiran and maximum tolerate statin, or 3.5 of PCSK9 inhibitors. But around the world, they may offer this at lower thresholds. Um, Finally, before we talk about the cases, I just want to let you know we've talked about LDL cholesterol, but it's not all about LDL cholesterol. Triglycerides, we know, also play a part in cardiovascular disease because we know that even though we've reduced LDL cholesterol down to very low levels, patients can still have ongoing cardiovascular events because of elevated residual triglycerides. And until now, it's been really hard to target them because statins don't tend to work for triglycerides. We might give them fish oils, but they don't tend to work. So there's just a new drug called icosapent ethyl or Vascepa, which is an omega-3 fatty acid called icosapentaenoic acid, which has been shown to reduce cardiovascular events by 25%. This is in the New England Journal of Medicine, compared to patients already on statin with really well controlled LDL cholesterol. So for now, we've got something to target triglycerides and reduce their risk further. Um, I won't talk about this. So I'll leave that there. And these are just the criteria for using Vascepa. But again, it's not really much about. We're talking more about LDL than triglycerides. So before we finish up with the cases, has anybody got any questions at all before we go through the cases that I just put at the start, just to see what people think about them?
Thank you so much, dear doctor. It's splendid, beautiful, beautiful. Yes, and we have a couple of beautiful questions by Dr. Zainab.
Thank you, Dr. Zainab.
She asked about a beautiful question. When converting from one statin to another, do you reduce the dose, particularly if you are upgrading to a more potent one?
So it all depends on the patient. So if
Mm.
uh, so if somebody has muscle aches and pains or has memory impairment or for whatever reason can't tolerate, say, atorvastatin 40 milligrams, um, I'll either say to them, "Well, we'll reduce it down to 20 milligram, or I'll switch them to rosuvastatin." But I will always put them on the lower dose of a new drug. So I'll put them on, say, 5 milligrams of rosuvastatin, and then I will up it to 10 and then 20, because atorvastatin, rosuvastatin is so atorvastatin 40 is equivalent to rosuva 20. Atorva 20 is equivalent to rosuva 10. So whatever the dose of atorvastatin, the equivalent potent dose is half of rosuvastatin. So I would always start at the lower dose. If I'm going to but the cardiologists don't often do that. The cardiologist someone's had a myocardial infarction, someone's got heart disease, they put them straight on 80 milligrams of atorvastatin. We don't tend to do that in the lipid clinic. We tend to start slow. We tend to put them on 20 and then we build up to 40. So in answer to her question, if they can't tolerate the statin or they're having difficulties, we'll always put them on a lower dose of another statin. Um, if we're so and if we're up titrating in our lipid clinic, we always up titrate slowly. 20 milligrams, 40 milligrams of torvastatin plus or minus 80, rosuvastatin 10, 20, 40. That's what we tend to do. That's what we tend to do in the lipid clinic.
Beautiful, beautiful. So the next question by Dr. Zainab also is, what are the cases when you prefer using pravastatin, which is the least potent among all?
Okay, so pravastatin is an old drug. We don't tend to use it very much because it is not very potent, as you rightfully say. There are some situations where we'd use it where patients are in. So normally we could use it in primary prevention. So if you remember, we were talking about inclisiran and PCSK9 inhibitors. These are licensed for use in secondary prevention, patients with established coronary artery disease. So we try and put them on that. But if you've got somebody who is, got a high Curis score, doesn't have any calcification on CT, but you want to prevent them from developing coronary artery disease, then we'd always start them on atorvastatin, and then they can't tolerate atorvastatin, then we put them on rosuvastatin. They can't tolerate rosuvastatin, Normally I'd put them on ezetimibe and another drug called bempedoic acid, but if they can't tolerate anything, then I'll put them on pravastatin. The reason why pravastatin might work at a low dose, like 10 milligrams, is because pravastatin has a different metabolism to atorvastatin. I don't know if you've heard of these phrases, hydrophilic and lipophilic type statins. Pravastatin is thought to be less lipophilic than atorvastatin, so it's not thought to get into the muscle so much. So there is some basis where patients can tolerate it more because it doesn't get distributed in muscle tissue because it's less lipophilic. So some patients, I'll put them on 10, 20 milligrams and they're fine, but only people for primary prevention who've not got established cardiovascular disease, and you're not really worried about getting the LDL very, very, very low down, if you're running out of options. I might also use it on patients who are on drugs that interfere with with cytochrome P450 metabolism, because some of the immunosuppressants, anticonvulsants, they will interact with atorvastatin and rosuvastatin because of the way they're metabolized. Pravastatin has very little activity on the cytochrome P450 of the liver, so I'll tend to use it in those where I'm not worried about interaction, where I'm worried about potential interaction. So they're on anticonvulsants, yeah, and I'm thinking, okay, all I've got is ezetimibe or bempedoic acid. Let's put them on pravastatin, because pravastatin generally won't interfere with that. But apart from those two scenarios, very rarely would I use pravastatin.
Okay, thank you. Very clear. Another question by Dr. Zainab also. So, could you give us an idea about efficacy of omega-3 fatty acid in a patient with dyslipidemia, and what are the risks of Vascepa in a patient with high baseline uric acid? So,
But the uric acid. So uric acid, I think you mean bempedoic acid. So bempedoic
um,
acid, which I've not put here, is a drug. So bempedoic acid here is a drug which reduces cholesterol synthesis in the liver. It works on an enzyme called a citrate lyase, which works further upstream of cholesterol synthesis. It's a prodrug, and often, and because it's a prodrug, it doesn't get metabolized in muscle. So we often use it in primary prevention in those who can't tolerate statins, and we can't use PCSK9 or inclisiran. In trial, bempedoic acid was shown to raise uric acid, and obviously. So if you've got gout and you raise uric acid, then you increase the risk of developing further gout episodes. So we used to check uric acid in everybody before we start it. Now we don't bother. We only don't start it in somebody who's had a confirmed history of gout. Like if they were on a thiazide diuretic, we wouldn't put someone back on a thiazide diuretic if they had gout. We wouldn't generally use bempedoic acid if they use gout, but we don't worry about uric acid. We don't measure it, we don't test it. We just ask them if you've got a history of gout. If the answer is no, then I'll put them on bempedoic acid. Um, and that will result in generally a reduction of around 20 to 25% reduction of LDL cholesterol. So not as potent as statins, similar potency to ezetimibe. I don't know if she had a second question about icosapent ethyl Vascepa. Am I sorry? I missed that.
no, the question about Vascepa is the risk of Vascepa in a patient with the high baseline uric acid.
So with Vascepa is purely for triglycerides. So it's a fish oil used to lower triglyceride. It has no association with uric acid. It doesn't raise uric acid. The risk of Vascepa is bleeding, gastrointestinal bleeding, because I think it interferes with vitamin K metabolism, and the other risk is uh, the other risk is atrial fibrillation. In the trial data from Reduce It, there was a higher proportion of patients that developed atrial fibrillation, new atrial fibrillation on Vascepa. So we just warn patients saying, there is a slightly small risk of developing atrial fibrillation. We don't know why, and there's a small risk of having a gastrointestinal hemorrhage, non-fatal gastrointestinal hemorrhage, but gastrointestinal hemorrhage nonetheless. So you just make them aware. They're the only two risks associated with it, but there's no other risk with uric acid. with Vascepa. But Vascepa primarily works on triglyceride lowering, so we only use it in those patients whose LDL cholesterol is to target because they're on high potency statin, but who have residual hypertriglyceridemia, because we've shown in data that patients with residual hypertriglyceridemia still go on to have cardiovascular events. And we've now got a drug that can target triglycerides so we use icosapent ethyl for that. I hope that answers your question, Zainab.
Thank you so much, they are very clear. And we have another question from Dr. Heidi Hamid, and hope I have the same question as she. The first one is, can we start statin in a high-risk patient when target is reached?
So high risk patient, I presume you mean somebody with secondary prevention. The answer is no, absolutely not, for two reasons. Um, if someone's had a heart attack or someone's got atherosclerotic cardiovascular disease, um, when you put them on when if you stop their statin, the LDL cholesterol will come back up. It almost always comes back up, and it will never be at the level that you've got them down to 1.4 millimoles per liter, so it will start to rise. The second point, which is just as important, if not more important, statins have what we call a pleiotropic effect. It doesn't just lower LDL cholesterols, it stabilizes plaques. So remember, right at the start, we were saying about plaque stability, vulnerable plaques. Statins have been shown not only to regress plaque formation, to actually regress them, but they've also shown to make plaques more stable, because they improve the architecture of the plaque, they calcify the plaques, and have been shown to make them more stable, i.e., less likely to rupture. So, the absolute answer to that question is no, certainly not in high risk patients, and definitely not in those who've got established cardiovascular disease.
Beautiful. So the second question by Dr. Heidi, is there any relationship between SGLT2 inhibitor and lipid management? And
Uh,
we can approach this question to say, what about that patient with diabetes? So I previously read that patient with diabetes type 2, after 40, it's mandatory to give them a prophylactic statin. So
yeah,
is
so
it?
so that's nice. So NICE guidelines say that if you're to follow NICE guidelines, they say yeah, 40. They use 40 as a cutoff with diabetes in type 2, or they say if you've had type 1 diabetes for 10 years, then you should go on a statin. If you follow European guidelines, they'd probably say start them on a statin fairly soon, but keep the LDL cholesterol around 2.6, unless they've had it more than 10 years, and you go for lower LDL cholesterol, because they're more likely to have developed atherosclerotic cardiovascular disease. Um, in terms of SGLT2 inhibitors, I'm not aware, and I'm happy to report, I'm not aware of any association between SGLT2s and lipids, as far as I'm aware. I mean, SGLT2 inhibitors, dapagliflozin, empagliflozin, have a wealth of cardiovascular data with them, from the cardiovascular outcome trials. So DAPA, EMPA-REG, they've shown reduction in cardiovascular outcome, improvement in cardiovascular outcome data in diabetes, but I don't think it's mediated through LDL lowering. I think it's mediated through uh, renin angiotensin, cardiac remodeling, renal perfusion. So it has a completely different mechanism, anti-inflammatory mechanism. So, but it's not mediated through LDL reduction. It's mediated through a different mechanism. So, but like you said, we work, those that work in this field are metabolic medicine physicians. So you don't just look at cholesterol on its own. If I saw a patient with diabetes, with proteinuria, with heart failure, I would be putting them on ramipril, I would be putting them on Entresto, I would be putting them on an SGLT2 inhibitor, I'd be putting them on spironolactone, and I would also be addressing their blood pressure putting them on a statin if their LDL cholesterol is raised. So controlling their diabetes. So you look at the whole picture. You don't just address the lipids. So you look at everything: blood pressure, lipids, diabetes. They're the three big things. So yeah. So you're right in many ways. SGLT2 inhibitors, there is a role for it, but again, the other cardiometabolic renal problems, but not specifically via LDL um, mediating or mediation, if that makes sense.
Thank you so much. Dr. Zainab, at the point here, she said that SGLT2 increase the lipolysis, therefore have a modest lipid lowering effect, mostly on triglycerides.
Okay, no, that's absolutely fair. I mean, thank you very much. I wasn't aware of that. Um, so lipolysis, so yeah, no, that's brilliant. We don't routinely use it in the lipid sphere, but if there's data that's saying that it inhibits lipolysis, that's fine. Um, I only wonder whether its mechanism is through increased insulin sensitivity, because we know when you give patients insulin, or if after you've eaten, you get a postprandial rise in insulin. Insulin prevents lipolysis. It prevents the breakdown of triglycerides into free fatty acids and glycerol. And when you give insulin, you prevent lipolysis. So if you improve glycemic control by whatever means, whether you give them insulin or whether you make them more insulin sensitive, which whatever drug you give, then you will definitely improve insulin sensitivity, and that insulin sensitivity will improve lipolysis. So I wonder whether it's more of an indirect mechanism rather than a direct mechanism, if that makes sense.
Beautiful. So we may ask Dr. Zainab to, if she has the answer for this point, um, uh, kindly if she can unmute. Um,
I
the third question,
yes,
yeah,
as you said, it's indirect mechanism through the beta oxidation and transportation of lipid into the cell, and in a way as well, it's through the starvation effect, because they have a they lower blood sugars, and there is a state of low calorie state, and the body shifts towards breakdown of lipids and therefore lowers triglycerides.
Okay, no, that's fascinating from my perspective. No, that thank you very much, and that's another mechanism. I guess it just shows. I guess it shows you how it's all intrinsically linked. We, like I said, we don't just look at lipids in isolation. We don't just look at diabetes in isolation. We don't just look at blood pressure in isolation. You have to think about cardiometabolic renal. That's the buzzword now that they use here: cardiometabolic renal, which incorporates all of it together. So they all have a direct and indirect interplay. So that's a very good point, Zainab.
Great, thank
very
you.
well integrated. Thank you so much. So yes, we can go through cases.
So the cases, oh, hopefully won't take, because I've taken so much of your time, and I apologize. We'll just go through these two cases, and this is open out to the floor, really. I don't want to. I don't really want to talk. So this is our 63-year-old man. He's hypertensive. He's got type 2 diabetes. He's got coronary heart disease. And these are his list of medications. I've highlighted in red his dual lipid lowering therapies: atorvastatin 40 and ezetimibe 10 milligrams, and his other medications here. So all I want to know is, so next question. These are his lipid profile. So his total cholesterol. I don't. You choose. This is the milligrams per deciliter. This is millimoles per liter. Choose whichever unit you are comfortable with. I do not understand these units, so it doesn't mean anything to me. But it might do for people who use mass units. But these are his units here. I guess the question is, and I'll leave it to the floor after what we've discussed. Are you happy with these values? Open discussion. People shout out.
Can you go back on the case just to see the past history? No,
Why not?
because he has coronary artery disease and his LDL cholesterol is above recommended target.
Yeah, absolutely. You know, the LDL cholesterol of 3.1 is going to not do much. Yes, we've lowered his relative risk we've increased his relative risk reduction. If he started at 5, his relative risk reduction is 50%. We might have improved his absolute risk reduction by several percent, but his LDL cholesterol at 3 is way above target. This person will continue to develop further atherosclerosis. We want to knock his LDL cholesterol out. We really want that as low as possible. We want it below. So NICE guidelines says 2, but we don't follow NICE guidelines. We follow European guidelines. We want it below 1.4 millimoles per liter. So what are we going to offer him? He's bearing in mind he's on atorvastatin 40 and ezetimibe 10.
So there is a chance. I mean, it depends on your what's available in your locally. There's a chance to increase the atorvastatin to maximum dose and see how it works.
You could do, and that's
Yeah.
and a lot of people do that. But what did I say? What's going to happen when you increase the atorvastatin to 80?
Not much. And he may develop as well side effects. But the other option, if inclisiran is available, then inclisiran would be the best option here.
Absolutely, yeah. I mean, so the way I look at it, because you've got cardiovascular outcome data for PCSK9 inhibitors, I'd always try and go for PCSK9 inhibitors first. However, in the UK, we cannot give PCSK9 inhibitors to those who have an LDL cholesterol below 3.5 millimoles per liter. So in secondary, so they have to have an LDL cholesterol of 3.5 millimoles per liter before we can give them before we can give them a PCSK9 inhibitor. But we can give inclisiran because the funding threshold in the UK is 2.6. So he's on a maximum tolerated statin, and I count atorva 40 as maximum tolerated statin. So I count 40 milligrams as maximum tolerated. I'm not going to push up to 80, and there was already on ezetimibe. So his LDL cholesterol is 3.1. I would give this gentleman inclisiran. And that's what we did. We gave him 2 doses of inclisiran in the hospital. We normally give it as the first dose at baseline, second dose at 3 months, and then we ask the GP to give every 6 months if they're happy to give it. We also try to improve his HbA1c because if you remember, cardiometabolic renal, we can't just look at lipids in isolation. You have to look at their glycemic control. This was his results that came back. Next set of results. Are we happier with that?
Yes. Just a question, Amro. When these injectable agents are not available, I'm not sure if they are available in Iraq or in the Middle East. What are the options other than
it's a difficult one.
tablets?
There isn't. So this is what you have to check. And again, I moan about the NHS and the resource poor NHS, but we're so lucky with the access of some of the drugs we do have on the NHS. If you do not have access to PCSK9 inhibitors or inclisiran, then you are left only to increase atorvastatin to 80 milligrams. I think that's the only thing you can do, because you're not really going to adding bempedoic acid isn't really going to make that much difference because you're working on the same pathway. If you remember, bempedoic acid is a prodrug. You're only working on the same pathway, so it's not really going to do much, and you increase your chances of myalgia when you combine high dose statin with bempedoic acid. So really, the only thing you can do is increase atorvastatin to 80 milligrams. So that's, but you'd have to obviously check whether these are available in Iraq and how are they funded as well, because I suspect patients are going to have to privately fund these, and these are expensive drugs.
Actually, yes, they are. Yes, it's not available by the government or by public hospitals. It's just in the private pharmacies. Yes.
Yeah. So I mean, the NHS pays, just to give you an idea of cost, the average cost per year of a PCSK9 inhibitor like alirocumab is around £5,000 a year per patient. So the average cost of atorvastatin 40 milligrams per year is around 40-50 pounds. So so statins, so that's why they want people to go on statins first, and then the guidance for funding here is you have to try 2, in fact 3 different types of statins. We never try 3, we say 2 different statins before you put them on these more expensive drugs. So they're in the order of magnitude, they are 100-fold more expensive than statins, which is a shame, really. So what would you do then? So you're happy. I mean, we're happy with the LDL cholesterol. We're less than 1.4. I don't know what it is in milligrams per deciliter, but we're less than 1.4. Our total cholesterol HDL is fine. Are you happy with the triglyceride level?
I would prefer to be a little bit lower.
Yeah. So you prefer it to be low because we've established that in trial in observational data, patients with cardiovascular disease, even though we've got their LDL cholesterol, we've wiped out their LDL, they still have residual patients with residual hypertriglyceridemia are at risk of having events, further events. So so for the first time, we have a drug that can target triglyceride and reduce and reduce cardiovascular outcomes. What's that drug?
The skipper, the
Yeah,
omega-3.
Vascepa. Icosapent ethyl, 1,000 milligrams or 998 milligrams, 2 capsules BD. So that's what we gave him. I'm not gonna, just in the interest of time, I'm not gonna talk about Vascepa has its own problems, and it's a massively controversial drug. In fact, I am just going to quickly talk about it because some people don't prescribe Vascepa, even in lipid clinics. This is the trial data for Vascepa. If you have a look at the placebo arm, they used something called mineral oil in the placebo arm. Mineral oil is a really weird oil to use for placebo. Normally, for placebo, they use corn oil, but in this trial, they used mineral oil. Look what mineral oil did to the placebo. It worsened patients' lipid profile. So it worsened their triglyceride, it worsened their non-HDL cholesterol, it worsened their LDL cholesterol, it worsened their ApoB, it worsened their highly sensitive CRP, so their inflammatory markers. So what people are asking is the effect, the 25% reduction in cardiovascular outcomes, has that actually been magnified in the treatment group by worsening the parameters in the placebo group? Just just makes you think about that. But we still gave it anyway. Because he's met the target for NICE. He's got established cardiovascular disease. His LDL cholesterol, we've got it down to target, it's down to above 1.4 to 2.6, and his triglycerides more than 1.7. Finally, case 2. This is a gentleman who's been found to have moderate hypercholesterolemia. Bloods were performed privately, as they do in private clinics. Found to have 8.5. They told him, go and see your GP. By the time he got an appointment with his GP, it was 6 months later. And these are what the GP, bloods for the GP. What can you see here? What are the things that stand out?
Okay, so I can see an elevated triglyceride here, an
Yeah.
elevated PC level, and uh, good HDL level, and okay, so elevated hypertriglyceridemia here
Yeah, so
with elevated TP. Yeah.
so he's got a mixed dyslipidemia with a
Yeah.
very mild elevated triglyceride. He's, as you
Yeah.
rightfully say, his HDL's normal. His LDL cholesterol's raised. 5.5 is high for a 48-year-old man. So he's also got elevated. Remember what we said right at the start. One of the family members of LDL cholesterol, something called lipoprotein little a. Lipoprotein little a is very highly atherogenic, small dense lipoprotein. His is significantly elevated, which puts him at higher risk. This is an independent risk factor for cardiovascular disease. So this chap is actually at high risk of developing cardiovascular disease. So this is his history here. He's got no past medical history other than being slightly overweight. He's not on any medication. His father had a fatal MI age 61. So that's a bit worrying. His dad had an MI at 61, which makes you think there is a genetic element here.
Yes.
Either he might have familial hypercholesterolemia based on his elevated total cholesterol, though normally it's a bit higher, or it might be that his father also had elevated lipoprotein little a, because this is genetically predetermined. You're more likely, if you have high lipoprotein little a, one of your parents or both are also more likely to have elevated lipoprotein little a. So this person is at high risk. So so this is what we did. What next? We did we checked his FH genetics, familial hypercholesterolemia genetics. I won't bore you with what it means, but he didn't have monogenic cause. He didn't have familial hypercholesterolemia. He had something called polygenic hypercholesterolemia, which is higher risk than normal person. What would you do? What would you do in this person? Would you say no treatment, offer treatment, go and lose weight? His BMI is 27. What would you do?
I think we will start with a combination of all of this. Of course, diet changes and lifestyle modification, and of course, we'll add statins, and even I think we should add maybe as a
Ezetimibe.
azetamide, yes,
Yeah,
azetamide.
that's a good shout. In fact, we did actually ask him to lifestyle modification. I haven't written it down. I think he came back and his LDL was still high. And as you rightfully say, we put him on a statin. We weren't happy just to leave him. I think his Curious score was only yeah. So we put him on a atorvastatin 20 milligrams. We said, okay, let's go on 20 milligrams. He couldn't tolerate it. He developed muscle aches and pains around his legs. So he was like, I'm not going back on the atorvastatin. He threw it back in our faces. So as Zainab asked before, what would we do? We put him on rosuvastatin 10 milligrams. In hindsight, maybe should have put him on 5 milligrams at the lower dose, because this is the equivalent of that. And maybe we should have put him on 5 milligrams just to try and build him up slowly. But he muscle aches, headaches, brain fog. So we stopped it for a couple of weeks, put him on 5 milligram dose. Didn't work, felt exactly the same, saying, I'm never taking statins again. These are horrible drugs. So then we put him on ezetimibe, as you rightfully said, because he couldn't tolerate statins, 10 milligrams. So he could tolerate the ezetimibe. But 3 months later, we checked his lipids, and they were his lipids there.
Yeah, azetamide not enough.
Yeah. So what did we say was the average LDL reduction of ezetimibe alone? Do you remember the
It's about
percentage?
alone is to about 22% alone.
Yeah.
But if
Yeah.
we combine it with a statin, it may reach 27%.
So if you combine it with
Yeah.
if you combine it with a statin, yeah, you'll get an extra 27%,
Yeah.
above and beyond the statin. So the statin itself is 40, 50%, but if you add ezetimibe to a statin, yeah, absolutely, you get up to 27%. So you're right. So we've probably got a 20% reduction here. His LDL cholesterol is 4.2. Am I happy with that? Somebody strong.
Not really.
Yeah, I'm not happy, because if you're going to follow European guidelines, you got somebody. I would say this person's at high risk primary prevention, because he's got a strong family history. He's got an LDL cholesterol of 4.2, where and he's got an elevated lipoprotein little a, which again puts him at higher risk. So we weren't happy. We tried him on bempedoic acid, which I didn't talk about before, which is the one that higher up, it's a prodrug in cholesterol synthesis. Couldn't tolerate it. We tried to re-challenge him with pravastatin, and then someone tried him on weekly rosuvastatin. No, he's like, I'm not happy. I don't even think he wanted the rosuvastatin. What would we do?
Yeah, so it might be has an intermediate risk. So we don't have yet the cutter age. So could we do the CAC scan for him?
You absolutely,
How
yeah.
with the to measure the calcium in his artery, يعني, calcifications of the arteries here.
You're completely right. And the first thing I asked is this primary or is this secondary prevention? Because he's not got a heart. Clinically, he's not had a heart attack. Clinically, he doesn't have angina or peripheral vascular disease or have a mini stroke. But primary prevention does not become secondary prevention overnight. You don't just suddenly have a heart attack from not having atherosclerosis a day before. You develop coronary artery disease over many years. And as you rightfully say, we do not even know whether this person has secondary prevention coronary artery disease or whether this is pure primary. So you're right. This person who's intermediate to high risk, really we wanted to better risk stratify him, especially if we're going to use these drugs here, which can only be used in the context of secondary prevention in the UK. So we want to risk stratify him, and we want to offer the opportunity to use these drugs, which cannot be used in primary prevention. So he could have had a CAC score and perhaps should have had a CAC score, but he ended up having a CT coronary angiogram. And this is a really grainy image, I apologize. But you can see with a CT coronary angiogram, they also have measured his calcification here. You can see that area of calcification there. So he already has a degree of calcification, presumably in the left main stem here. And there was a degree of narrowing as well. This was the report. So he's got a calcium score of 4.7. It's not very high, but it's still not zero. So in his centile group for his age, he's probably somewhere between the 50 and 75th centile. So, but he's also got so he's got small calcific plaque in mid-vessel causing mild stenosis. So this is a calcific plaque. Sorry, that it should have been a better image, and I apologize. But if you believe me, on there's been a small plaque that they noticed here as well, which is which was noted here. The rest of his coronary arteries were normal. So they said this person had non-obstructive left anterior descending plaque here. So is this primary prevention or secondary prevention now?
Okay, there is a risk of obstruction at the end of the day, so we can say it's a primary one
Well, there's a risk of it's non-obstructive. So at the moment, it's not obstructing because
in the moment.
at the moment. But if you were to leave it for 5 years, 10 years, there
Surely,
is a risk this will become obstruction, and there is a risk this could rupture in that time and cause an MI. So, we would label this as secondary prevention. We'd say this person has higher than average because he's above the 50th centile for his age, um, higher than average coronary artery disease, even though it's non-obstructive, higher than average coronary artery disease for a man of his age. And so I would say this is secondary prevention. He's already, when we looked at that boat of 5,000 milligrams cumulative, he's already way above that. If we leave him another 5 years, he is at significant risk of having a heart attack, or he's at significant risk of angina. We want to prevent that from happening. We're not going to wait for his heart attack to happen. So we would label this as secondary prevention. So what we did is, because his LDL cholesterol was greater than 4 or 3.5 in high risk or very high risk, this is funding UK criteria. We put him on a PCSK9 inhibitor. So we put him on alirocumab, and you can see literally he's already somewhere up here, isn't he? He's 48. He's already got evidence of atherosclerosis. So if you leave him another 5 years, he might get to the point where he has an MI. So we want to try and push him somewhere down here and attenuate that risk. For instead of 5 years, we want to push it down the can down the road 10 years or 20 years, so that he might die of something else, like cancer or something else, in essence, that's not heart disease. So we gave him that, and that was his cholesterol there. That was at 6 months later. So his LDL cholesterol has rapidly moved down. It's moved down to 1.3. So we've got him to target according to European guidelines. So we're happy. Yes, his triglyceride level is mildly elevated. We could put him on Vascepa. I don't think we bothered in the end because, again, the Vascepa is very controversial because of this mineral oil in the placebo group. But we have protected this man from his main risk, which is LDL cholesterol being lower. His lipoprotein little a is still high. Most drugs don't affect lipoprotein little a. PCSK9 inhibitors do lower it slightly. And again, there are newer drugs at the moment that have started to target lipoprotein little a, but we're not going to talk about that because they're all in development. But the most important thing is we've lowered his LDL cholesterol. So hopefully, this man who is asymptomatic, who has an area of calcification in his left anterior descending, we can now treat him to target with a newer drug and prevent him from developing symptomatic coronary artery disease or developing a plaque rupture. So hopefully we've done a good thing by this man. So we've pushed him now because he is high risk. He is high risk down here. It says here, atherosclerotic cardiovascular is clinical or imaging. He doesn't have clinical, he's got imaging risk. So we need to push this right down, get him down to 1.4 millimoles per liter. That is all of my slides. I have tortured you for almost 2 hours, for which I apologize.
Totally not, dear. You are amuse us actually. So splendid lecture. Thank you so much for this integration.
No, thank you. Thank you. Thank
Very
you so much for having me.
appreciated.
Are there any questions at all that people want answering, or?
Okay, so do you have any questions, dear participants? You feel free to ask any question or even unmute yourself.
Thank you
I
very
think
much,
everything.
Amro. Thank you.
Thank you, Dr.
Really
Zainab.
No,
brilliant lecture as always. Very interesting to listen to you. Thank you, Amro. I always learn from you every time.
oh, thank you. That's very kind of you. As long as there's something I can teach, I'm more than happy. And we learn from each other. You know, we're very lucky to have a fantastic group of people in the region, and also what you've created here in the with the Iraq London network. It's fantastic, and hopefully it grows from strength to strength. So yeah, no, thank you for inviting me.
You're most
Inshallah.
welcome. We're privileged.
Thank you so much. All right. Oh, shall I? I've stopped sharing anyway, and that's me done.
Oh, thank you so much, dear sir. Special thanks goes to Dr. Zainab Akram. Without her, this meeting will not be occur. So thank you so much, dear sir. We hopefully this is the first lecture with us privilege to have you within us, but hopefully this is not the end. We have a lot. Actually, we are so pleased with you. You undoubtedly enrich our understanding and spark meaningful discussions. Thank you so much.
No, thank you for having me. That's very kind of you. Thank you very much.
Thank you so much. Thank you for your dear attendees. Hopefully, inshallah, we will meet again. Uh, keep keep in touch. Follow us on our chat and our platforms. Thank you so much. Have a nice rest of your day. Thank you.
Thank you. Masa and Bobby.